Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Thanks for listening to Behind the Knife. This is Jason here. Let's be real. Prepping for the cardiothoracic boards can feel like drinking from a fire hose. That's why we built the Behind the Knife Cardiothoracic Board Review, to make the hard stuff easier. It has over 70 high-yield scenarios covering everything from lung cancer to ECMO, plus high-yield audio commentary from cardiothoracic faculty who've been in your shoes. Whether you're deep into fellowship or reviewing before the exam, this is the one-stop resource you need, all on the Behind the Knife app. Group discounts are available. Enjoy the episode and dominate the day.
Welcome to Behind the Knife. I'm Kyla Rakoczy, a PGY3 general surgery resident at Johns Hopkins, and today I'm thrilled to be joined by an expert in thoracic surgery, professor of surgery at Johns Hopkins, Dr. Stephen Yang. Dr. Yang is extremely clinically active, a fierce medical student and resident advocate, and master surgical educator. It is a distinct privilege to get to learn from and work with you, Dr. Yang. Thank you for being here.
Well, thanks, Kyla. This is really a great honor and a thrill for me to be on Behind the Knife. I've listened to a handful of these. I'm very excited to do this. Hopefully we can do another one. And for the audience out there, Kyla is a great resident, so you'll be hearing more from her in the future. So don't recruit her away from me, please.
Thanks, Dr. Yang. I'm pretty excited to be here with you, too. Today we're going to be discussing robotic segmentectomy. To provide a brief historical context, segmentectomies weren't always used in lung cancer surgery as they are today. Oncologic thoracic surgery has been evolving over the years. Back in 1912, Dr. Davies performed the first lobectomy specifically for lung cancer. After that, in 1933, Dr. Graham did the first pneumonectomy. This maximally invasive approach was the standard for years until the 1950s and 60s when Dr. Kahan popularized the radical lobectomy. Then, the management of early-stage lung cancer, specifically those with small peripheral tumors, got more controversial into the 1990s, when the idea of using a more limited sublobar resection entered the scene. In 1995, the Lung Cancer Study Group published a randomized control trial that found, because of higher death rate and local regional recurrence rates associated with more limited resection, lobectomy should still be considered standard of care for peripheral T1 and 0 non-small cell lung cancer. This was accepted for years, until advancements in CT imaging reignited the conversation about sublobar resections, which resulted in JCOG 0802 and CALGB, which together gave rise to the use of sublobar resections for these early-stage peripheral tumors. What was it like practicing through some of those changes? What advice do you offer surgeons in general with regards to the need to constantly adapt and evolve?
Yeah, so thanks, Kyla. I've been in practice for 30 years now, and if you add another 10 years during my training, practice has really changed pretty radically. I might give a Hopkins plug for Dr. William Rainhoff. So he was a thoracic surgeon here at Hopkins and also performed the first pneumonectomy for lung cancer in a patient that eventually survived. Chronologically, he did it before Dr. Graham, which is some debate, but he didn't get credited for it. Dr. Rainhoff actually did what's called individual ligation of the artery and the vein and the bronchus, which is what we use these days. Dr. Graham and his colleagues all did a big tie around the hilum. So you can see even from that, we've evolved technically in actually how we take out the different sections of the lung. And so it has changed. What I usually tell folks is that what you're practicing now will probably not be what you're going to be doing in 20, 30 years. And if you're still teaching what you're doing that you trained in residency, you're going to be behind the time. It's good to be open. You're going to go through this lifelong learning, so your techniques will change. But it's also important to really know everything. So just because we're doing mostly robotic doesn't mean you shouldn't know how to do thoracotomy or that. So I think it's important to know all the techniques, and you all are going to be challenged because as technology changes, you're going to have to know that as well as know some of the old techniques. It has been game-changing as far as the different techniques from open to robotic. When I was training, we were doing big posterior lateral thoracotomies even for wedge resections. Most of our lung resections now, obviously, are lobectomies, but they did do quite a few open segmentectomies. And I've always felt that segments were appropriate for smaller tumors, and we were part of the CALGB trial, and that took about 14 years to get the final results. But I think it's important that you should know where we came from in order to progress in the future. But that's why I spend a lot of time on history. I love teaching history. So the other thing is that when you first start your practice, yes, segmentectomies are pretty sexy. And you got to do what's right and do what you're comfortable with. So when you first start out, don't do a complex robotic segmentectomy, which will take hours. But what I do tell folks that your first case when you start your practice will define you. So if you do a complex operation for your first case and it takes hours and you may have complications, that will unfortunately define your practice. Start out easy, do a quick wedge. If you want to do a segment, you can always do an open, or if you're more comfortable with that, so if you haven't had any robotic experience, just do something that you can get done easily so that people know that you're a competent surgeon. And the other is that as you start moving forward, make sure that you adhere to the standard oncologic principles, that sample the nose or dissect out the nose, that you check the margins, that you look at your long-term results. So, not only see the patients for the first post-op visit, you should be seeing them long-term to make sure that if you are doing segmentectomies for these peripheral nodules, that your outcomes are good. Because if your outcomes aren't as good as lobectomies, then you're doing something wrong. And obviously we need to serve the public properly and not do something fancy just because we want to do it.
Excellent. As a resident, I do think it's exciting to latch on to all the technology and the beauty that is the robot, but it's important that we don't lose those open skills in the process. You referenced a little bit of the different complexity of the cases. Not every segmentectomy is created equal, that's for sure. A more complex segmentectomy versus a simple one is a resection where more than one intersegmental plane is divided. Segmentectomies require a really good 3D understanding of anatomy, and that's great in the robotic world. Advances in MDCT and volume rendering reconstruction software have allowed us to prepare for the highly variable thoracic anatomy which can be encountered. Specifically important is the identification of intersegmental veins, as these are the landmarks we use during segmentectomy to define the boundaries of the target. Dr. Yang, when preparing for a case with imaging, what are the most important things to consider?
Well, I think just the basic standard 3D reconstructions of the CT scans are important. I study the scans. I look at the sagittal cuts. I look at the coronal cuts. I try to follow on all the vessels. And these days with high resolution CT scans, you could see you could differentiate the PA segmental vessels from the pulmonary vein. So if you do that, and I think, again, I grew up the old fashioned way, you just do it. These days, there's a lot of other techniques used in the OR. If you divide the artery early, you can give ICG and see where it's not perfused. And certainly the old time when you cut the bronchus, you could see what part of the lung deflates. I don't use the inflation technique just because there is collateralization between the different segments. Those are called the pores of Kahn. Those of you studying for your board exam, you better know that. But sometimes you can actually see the intersegmental fissures intraoperatively. You can see some lines where especially if there's anthracosis in the lungs, you can actually see where it stops. So after I do the CAT scans, I try to make sure I know which segment it's in. Then I'll do the bronchoscopy to make sure the endoscopic anatomy is normal. If I'm not quite sure which segment it's in, I do use the robotic ion, and I'll bring the interventional pulmonary team, IP team comes in to mark the nodule. A, it's good to find where the nodule is, but B, it actually tells me which segment it's in. So specifically, if I have trouble with the segment 6, if it's in 6 or say 9, 10, they can tell me which segment it's in. And obviously using Firefly to find the nodule is important. So those are little things that I do to try to figure out these tiny nodules and intersegmental planes. And maybe just to step back a little bit, why is segmentectomy important? But these days, we're being much more aggressive, especially patients with borderline lung function. At least here, we have a lot of patients who have mets to the lung. And if they have failed systemic therapy, we can actually afford them a good survival with metastasectomies. Not all mets come out with wedges, and some do require a small segment. And so we have extended segmentectomies for pulmonary metastasectomies for certain patients.
When treating mets to the lung, preserving post-op lung function is of particular importance, as the patients may have recurrences which require reoperation. Segmentectomy also allows us to evaluate lymph nodes, which can offer valuable data to inform prognostication for the patient. So now you've reviewed all the imaging, thought about the patient, and decided that segmentectomy is the correct operation. Now you're in the OR. Positioning generally involves a left lateral decubitus with a flex bed to open up the intercostal spaces. Can you walk us through your setup when performing a robotic segmentectomy? What are the most important considerations when positioning? How do you think about where you want to place your ports?
I always prep for lobectomy. I'm a very simple surgeon. I don't want to have specific port placements for specific segments. The general rule for upper lobes, I go above the 9th rib through the 8th intercostal space. For the middle and the lower lobes, I will go through the 9th intercostal space or above the 10th rib. I like to put all my ports through basically the same interspace to prevent a lot of neuralgias. So I align all the ports up the usual hook and horn, so the ports are about 4 or 5 centimeters apart, and then I'll usually use an air seal port for extraction. Sometimes I can get by with just 4 arms, especially if the resident's not there. I use 5th port just for teaching, but I can usually get by without an air seal port. So that's how I start, where I put my port sites. Again, in general, for upper lobes, I'll use 212. On the right-hand side, they'll be on arm 2 and arm 4. On the left-hand side, they're in arm 1 and 3. And I think it's important, like on the right-hand side, I always put my Maryland dissector. So people like to use cautery, I always put it in the 4th arm. So I'm using my right hand. On the left-hand side, I actually like to use my left hand. So I'm coming through port 1 to do all my dissection. A lot of people still use their right hand through port 4. We should be bimanual. So I encourage you all, if you're doing left-sided surgery, to use your left arm, because it's actually a lot easier to go up that fissure on the left-hand side through port 1. Now, I don't modify the size ports. So now there's an 8 millimeter stapler, so you don't need as many 12 millimeter ports. If it's a very complicated segment, I usually do use 2 12 ports or 2, so I can have options for doing the stapler. So I'd rather be safe and have options as opposed to try to do what I usually do for a lobectomy. That's my port placement, and then we just start the dissection, and we get in there. You do a hilar nodal sampling or dissection if there's nodes that you're concerned about. The protocol said you do frozen sections in there, but I'm pretty comfortable with negative PET scans and negative E-buses that I just proceed and do my sampling and staging, and won't do intraoperative frozen sections. I consider there are 3 levels of segmentectomies. There's the easy, the moderate, and the most difficult. Easy ones are superior segment, posterior segment. I think the most difficult one is the left lower lobe segment 910, because you have to bisect the superior segment from the basilar segment safely without damaging the descending pulmonary artery, and then you just take out the posterior lateral segment. I think all the other ones are intermediate or moderately a difficult segmentectomy. When you're starting out, do the easier segmentectomies, and always make sure you're ready for disaster. Have small clips ready, have sutures ready in case you have trouble with bleeding. Make sure how to convert to an open operation quickly, and put a sponge or something to put pressure on the bleeder. Now, the other thing I tell people, don't push as hard as you can, because the harder you push, the more you tear the pulmonary artery. So just enough pressure to keep the bleeding from making an audible bleeding, and make sure that whichever arm that you're going to control with that bleeding is that it's out of the way and can control and can keep the tamponade as you convert to an open thoracotomy.
I think a lot of surgery residents out there can recall a time or two their left hand has been reminded to get in the game a bit more, myself included. And that tip about moderating pressure with bleeding, that's a good one. I can imagine the stress of that situation could cause someone to want to put a lot of pressure, but more isn't always better. I am curious, Dr. Yang. I know you're all about challenge. Do you have a favorite type of segmentectomy? What gets you most excited?
I do like those complex ones.
I figured.
Those difficult ones. Over time, when you get to my age, you're tired of doing the same lobectomies and you start varying how you... And again, this is just another teaching point. If you're doing lobectomies, I'm sure there's one way of doing it that people tell you, vary it a little bit, just because there are some times that, you have to change the approach. Like most people say for a right upper lobe, you go from posterior to anterior, but sometimes that posterior part is so stuck, so you do have to go anterior to posterior. Say you don't have a fissure, some people will do a fissureless lobectomy. Yeah, I think all segmentectomies are challenging. And, with the software, you should be able to predict the anatomy. I'm still an old-time search and destroy, but I do study the CT scans pretty carefully. So any segmentectomy is actually my favorite segmentectomy. I love doing segments. It's just where I think last time I heard we do the most here in the United States. But I think it's important. Don't do it just to do it, but again, make sure you do it for the right purpose. I always double and triple check myself. I think the other point, maybe related to a previous question, is that when you're not quite sure what instruments you're going to use, make sure you do think about it and let your team know. I sent an email to the team the night before to make sure they know which instruments I specifically want, how many ports, what size ports I want. Do you want the 8mm or the 12mm stapler?
There's clearly a lot of thoughtful preparation and technique that goes into these cases. But sometimes, despite these efforts, complications, including more common one like air leaks, do happen. Is there anything specific that you feel is a technique or an approach that keep your postoperative air leaks particularly low?
I think one is the meticulous dissection in the fissure. So I preferably like to get the PA first. I like to devascularize it so that lobe or segment doesn't get congested if you take the vein first. So I do take great care in trying to stay in the plane between the lobes. So that's one point. I think that does minimize some of our air leaks. And then when you're dissecting out the segmental bronchi, to stay right on the airway. And again, I was classically taught not to do that because it devascularizes the bronchus. But again, knock on wood, we haven't had a lot of problems with bronchopulmonary fistulas. So you just stay right on the plane of the bronchus so you don't violate that visceral pleura. When you staple, make sure you use the appropriate thickness stapler. I try not to cross the staples. One thing I do specifically for the superior segment and the basilar segment, I'll actually cut the superior segment like a pyramid. So like a little, I guess what we call the samosa. And so I'll cut it like a little pyramid. So you're not just going straight across the base and making that suture line so tight. So I'll actually take one stapler along the fissure where it's nice and thin, and then I'll come almost at 90-degree angles from the back and from the front to make it like a little pyramid. And so I do that if I'm doing a basilar segmentectomy or if I'm doing a superior segmentectomy. And I try to do that with some of the other segments as well. I think a lot of people think they just guillotine right across the base, but I think the thickness of the tissue can tear away from the staple lines that way. So again, if those of you are doing this and you're using the black loads and, when you close it and it takes a while for it to properly close all the way, I think if you take it from different directions and try to make it not so thick. And I think the other thing when you properly close the bronchus. Classically, when Reinhoff, what I talked about earlier, when you do the individual closing of the bronchus, you always want to close it from the cartilaginous rings to the posterior membrane, because if you close it at a different angle, then the cartilage is going to fracture. So I always try to make sure that when I fire the stapler that I close it like an anterior to posterior direction so that the cartilaginous rings come down toward the posterior membrane.
Wow, lots of pitfalls, lots of tips and tricks there, Dr. Yang. One of these days, I'm going to convince you that this should be a video recording. You can talk with your hands there. I think the people need to see it, but I know you're not about that too much. And I'm sure amongst everything that you just said, nothing's more valuable in avoiding the catastrophe in the OR or those complications than experience, which I know you just have so much of. So it's really been a pleasure talking with you, Dr. Yang. Last question. What excites you most about the future of robotic surgery? Where are we going from here?
So I think that technology will continue to get better. Just in my 20 years of doing robotics, I've already gone through 5 platforms. A new platform will come out, and there's different ways of doing it. There's going to be feedback. There's going to be ways that you don't have to stick your head out of the console. Everything will be automatic, and the images will overlay the lung. I know there's programs right now so that hopefully it develops a hologram of the lung so you can see the nodule as you're looking inside the lung. It sounds like science fiction, but that's where I think it's headed. And I think robotic surgery is just going to be getting better and better. So again, I think sky's the limit with surgery. I love thoracic just because we do so many different things. We have a very wide range of procedures that we offer. Robotic surgery and segmentectomies is just a small portion of that, but as I said, I love teaching you all how to do robotic surgery, and that it'll just get better.
Dr. Yang, this was fantastic. Your passion is evident. Some quick hits as we wrap up here. Number 1, reflect about where we've come from and be willing to adapt and evolve into the future. Number 2, preparation builds confidence. Use CT scans and 3D recons to create a map to your lesion. And number 3, vary your operative approach, perform meticulous dissection, and be sure to follow your outcomes. This is how we improve. So thanks so much for being here and reviewing robotic segmentectomies. It's been really special. Thanks, Dr. Yang. This has been Johns Hopkins Thoracic Surgery team signing off. Until next time, be sure to dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.